And while we're doing that, I'll just introduce our next speaker, who's Morritz Tannast from Switzerland, who's in good health now, I believe. And he's going to talk to us about athletic hip pain, differentiating from groin pain clinically.
Okay. Good morning, ladies and gentlemen. Thank you very much for the invitation. I enjoyed being here in Qatar. It's the first time I'm here in this area, and I like it very much. Now, for me as a orthopedic surgeon, it is a kind of unclear when you talk about hip pain and groin pain. I mean, hip pain for me is pain that originates from the hip. And groin pain is more like a symptom, which means that is pain that is located in the groin. But you can have hip pain that is located in the groin. So for me, it's a little bit confusion here in terms of nomenclature here. And I think what you really want to know is how do you find out if an athlete with recurrent groin pain has a hip problem or not. This is a kind of provocative, but I think it's a paradigm change going on. If you look at the PubMed search for groin pain over the last 20 to 30 years, then you can see this dramatically increase which is kind of exponential since the term femoral acetabular impingement has been introduced in the year 2000. And if you go back to some of the literature before this area, most people say, or a lot of people say, that the most common pathology found for groin pain in those athletes was an incipient hernia in about 50% of cases. And this is a kind of change, so the pendulum goes a little bit to the other direction, where we have some good literature on data that say that FAI was present in the majority of those cases with recurrent groin pain in athletes. We have even literature that says that 94% of all professional NFL players present with groin pain have signs of impingement. It seems to me a little bit a high number, but it just gives you an impression that it's relatively common. I think that hip pain may be falsely attributed to other disorders, and we see that over and over in our clinic. Hip pain can, of course, be present in addition to other problems, and the underlying FAI may be a cause of continued hip pain if you tried all the other, or if you have evaluated and tried all the other therapies for groin pain. Now, for me, it's a golden rule. So if you really want to make a diagnosis of impingement or for a hip problem, then the diagnosis has to be based on a positive correlation among patient history, symptoms, physical findings, and suggestive radiographs, and sometimes even intraoperative evaluation. And as an orthopedic surgeon, you have the privilege to just have a look at all of those features. And I think this is very valuable because you can really imagine what's going on in the hip if you examine a patient. I think it's totally inappropriate to diagnose an impingement just solely based on radiographs, and we get radiographic reports over and over where the radiologists say this is a femoral acetabular impingement. This is just not true, because you have features that can be consistent with a femoral acetabular impingement, but it is not possible just to do the diagnosis based on the radiographs. What about the patient history? Typically, these patients, they have a long-standing pain, so it's not the acute pain where they have to be come off the field, and it's rarely acute. It can be with or without initial trauma, and the pain can typically decrease or increase over time, but typically it will never get ultimately better. And you can imagine, once the labrum has torn due to an impingement mechanism, it would not have the possibility to heal back. Because there's impingement going on over and over. So this is the typical story that they have. You have to ask for hypermobility, because not only morphological features can lead to an impingement, but also hypermobility features. And we know, or we have the impression that we know nowadays, that vigorous sports activities in adolescence, as in high-level athletes, can really lead to those deformities. And you have to ask specifically for childhood problems. Now, here is one of our studies where we did MRIs on professional ice hockey players. And it's the same guy that we did an MRI on. He was asymptomatic at the year of 13, and he presented with this spherical femoral head. And after 7 or 8 years of conducting professional ISOK, he came back and he had some pain in his hip, and he presented with this asphericity. So he developed an asphericity over time during his growth spurt. So probably this is an indicator that sports or vigorous trauma to this epiphysis can lead to an alteration of the growth plate and finally end up with an asphericity of the femoral head. The symptoms are typical, so you have pain with or after athletic activities, and mechanical symptoms are quite common, like clicking, popping, snapping, or catching. And if you really ask the patients, they are typically aware of their limited hip mobility long before the pain even is present. So if they have problems with stretching during their warm-up, that is a sign that something probably already went on for a couple of years. Now, the pain location is not specific for impingement, and it may overlap with other pathologies. And I call it a kind of chameleon of the hip, so it can be anywhere. But I think a more sensitive sign is the reproduction of the typical pain with motion. So motion is the key factor for impingement, because without motion, you don't get an impingement. The location of pain, in my experience, correlates in part with the location of the impingement. So if you have an anterior impingement, then the pain is usually located more anteriorly. If you have a lateral impingement, usually more laterally, and a posterior impingement, usually more posterior. Here's a study by John Klahishi who summarized all the pain locations for impingement patients. And of course, most of the pain is located in the groin and in the lateral region of the greater trochanter, but you can have also pain that radiates to the posterior thigh, to the knee, to the anterior thigh. So you really have to be aware that this can be an impingement, and you have to reproduce this pain with motion. The pain character is typically sharp and aching. Sometimes it can be constant, intermittent, and once it got over to night pain, then you really have some severe degeneration already going on. Now, what about the physical examination? I think you have to go through a full range of motion. And I'm a little bit an opponent of those standardized dogmatic tests. So I think your clinical examination should have some standardized tests, but it should not be a dogmatic application of those tests. You have to detect the most pain-provoking motion for the individual patient, and then try to imagine what happens inside the hip. And then you have to do the correlation with the anatomy based on the radiographs. And this is really what is the most important point, and also the most difficult point. Tenderness or tenderness by palpation is usually not a primary problem in those patients. Now, when we talk about range of motion, then you have to say what is actually a normal range of motion. And we see in the literature over and over reports that somebody can flex up to 130, 140 degrees. This is just not possible unless you really have a large dysplastic hip, because the typical femoral acetabular motion is just about 90 degrees of flexion, about 10 degrees of extension, and about 25 degrees of internal and 35 degrees of external rotation. This is based really on intraoperative observation, so how the hip actually moves. And I encourage you really to go into surgery and watch how the hip would move, and then you will get an impression on how much you really move in the hip and how much you compensate with your lumbar spine. We think about 30 degrees of abduction, 10 degrees of adduction is what is normal. Now, let's come to those tests or to those range of motion evaluations. What about if you have pain in flexion, internal rotation, and abduction? This is the so-called impingement test, and I think it's a misleading terminology, because basically what it is it as kind of labral or labral tear test, because it refers to a labral pathology. And you can have a labral pathology even without having an impingement. For example, if you have a dysplastic hip, you also have a labral pathology, and this test will be positive, although you don't have an impingement. So I think it would be more appropriate to call this test pain in flexion, internal rotation, and adduction. It has a relatively good positive predictive value, although this is really optimistic, what I found in the literature, and the negative predictive value is rather low. And I perform it during different degrees of flexion. So you have to start with very, very few flexion, then come up to 90 degrees or even more flexion, in a little bit abduction if you can. And then you can find out exactly where the problem is in terms of the labral tear. And this correlates quite nicely with what you can see on the radiographs and also what you can see during the surgery. Here is part of our three-dimensional simulation. We are doing three-dimensional simulations of those hips. And this is the typical location if you have somebody with an anterior impingement and pain in internal rotation, abduction, and flexion. So it's typically in the anterior superior region here where you have the impingement location, and in the anterior superior region of the femoral head-neck junction. And these are the lesions that we see during surgery. So this is the acetabulum here, this is the labrum. Here on the left side will be anterior, on the right side posterior, and we typically have those labral tears and alterations in the anterior superior quadrant of the acetabulum. Now, what about if you have pain in extension and external rotation? This is referred to as the posterior impingement test. It can be positive if you have a very prominent posterior wall, or a positive or a prominent posterior asphericity. Or it can also be positive if you have a posterior extraarticular impingement between the lesser trochanter and the ischium. And this is typically the case also in dysplastic hips, where then it's more an apprehension sign, and it leads to kind of levering out of the hip anteriorly. So you have a posterior conflict that levers out the hip anteriorly, or has a tendency to do this levering. And here is a case with a prominent posterior wall on both sides, and you can see how in external rotation and extension there is this impingement with a three-dimensional motion on the right side. Here's what you can see during surgery. So the right side would be the posterior side. You have these alterations of the labrum, you have these alterations of the cartilage that are typically seen, and it's a completely different location that I've shown you just before. What about if you have just pain in pure flexion? Typically then you have a problem with the anterior inferior portion of the femoral head neck junction, or you can have it with a very deep socket, a very prominent acetabular wall. Typically we see that with a valgus hip, or if you have, and we have heard about that this morning, a low-hanging inferior iliac spine, and people just report pain by pure flexion, no rotation at all. So here's a case where we had the previous avulsion of the apophysis. On the right side again, the three-dimensional motion simulation with this extraarticular impingement between the inferior spine and the femoral head neck junction, or neck here in this case. This is a valgus hip, just a simulation by pure flexion, and these hips, they will impinge very, very anterior-inferiorly on the neck, and very inferior also on the acetabulum. And this is how it looks like during surgery. So the lesion is on the anterior-inferior side, which is now here on the left side. So it's completely different from what we've seen before here. What about if you have pain in slight flexion, abduction, and external rotation? So then usually it's often extraarticular impingement that we see between the greater trochanter with the ischium, and we found it typically with cases or with patients that present with an increased femoral torsion, and they also have limited external rotation. So for this patient here, we had this contact between the greater trochanter and the ischium that had been detected and that had to be corrected actually. Here is an athlete, it's a karate player that had exactly the same problem with a high antetorsion of the femur, and during one of those karate kicks she even dislocated her hip anteriorly because she had this posterior conflict, and there was an anterior dislocation of the hip. If you flex up more here and you come into maximal flexion, abduction, and external rotation, then you can have problems with very anterior-inferior pathologies or problems with lateral overcoverage of the femoral head or of the acetabulum. Here's a case with quite a subtle abnormality, which you can only see on this lateral X-ray here. It's a subtle abnormality in terms of a kind of bump formation. It would be located in this area here, and you cannot see anything on the AP radiograph. You can much better see it on a radial MRI, where you can really nicely see this asphericity here. And in this case here, you can produce with flexion, external rotation and abduction, a very anterior-inferior impingement. Now, sometimes you have a normal motion, but you have to take the femoral torsion also into account, because it can falsify or influence your range of motion measurements too. If you have somebody with a low antitorsion, as you can see here on the left side, then you will have less internal rotation and more external rotation in your physical examination. If you have somebody with a high antitorsion, you will have more internal rotation and less external rotation. And these hips, they can still impinge here if they have an additional cam deformity or so. It's very important that you take all those different features into account and not just focus on the cam deformity itself. This is how it looks like. So in the mid, you will have here this normal configuration with a slight antitorsion of the femur. Here you would have a neutral torsion of the femur, and this would decrease your amplitude of internal rotation. And on the right side, you have an increased torsion, and you will end up with a smaller amplitude of external rotation. We've just heard about that before quite nicely. What about the diagnostic intraarticular injections? We do it if you're not sure whether it really is an intraarticular pathology or not. And I think it is only positive if it is really an intraarticular pathology. For example, if you have a subspine impingement, usually the patients, they will not do better, because if it's only done intraarticular, they will not do maximally better, because it's not where the pain originates. And I always double check if I have somebody coming in who already had one of those injections, if it was really intraarticular, because very often I see images like that. And people telling me that this was a proof that they were in the joint. This is not an intraarticular injection. It's actually an injection of the iliocapsularis muscle here, which is just part of the iliopsoas muscle, which is just lying anterior to the capsule. And so if this one here was not positive, I would just repeat the intraarticular injection. And I always want to see those images, because I want to make sure that they really have been intraarticular. What about imaging? There are some general rules that are important, also for retrospective and prospective studies. If you want to do also some kind of epidemiological studies, you need to have 2 radiographs at least. One should be a correct preoperative anterior-posterior pelvic radiograph. And it's really mandatory that you take this under standardized conditions, and you take not like low-centered radiographs that you would just use as an orthopedic surgeon for total hip prosthesis, so that you can see the entire femur or most of the proximal femur. So, and don't use just X-rays centered over the hip. You will get a false impression of the version of the acetabulum. Now, you need a lateral additional radiographic view of the hip, and there are different views available. I think just one of the established views is okay to use. And then we basically always use, in those cases, high-resolution MRIs of the hip with radial cuts and with intraarticular contrast agents. And what we are looking for in those MRIs are labral lesions, chondral lesions. We are looking for asphericities that are not visible on X-rays, and we have approximately 20 to 30% of all the asphericities that you cannot see or cannot exclude with just conventional X-rays. So you need to go on with some further modality, which is here the radial cut MRI. We have nowadays also some novel biochemical sequences where you can try to monitor a little bit better or to quantify the cartilage damage that is already present in most of those cases. And then we, in our institution, add a 3-dimensional CT-based vertical simulation. Those were the images that I've just shown you before, and there are some other softwares out there that are commercially available. These are the 2 views that we are doing. We are doing an AP radiograph in supine position. You can discuss whether you want to do that in standing position, but we are doing it in supine position, because we can then reproduce once we want to do something during surgery or want to check an X-ray during surgery. We can directly reproduce and compare it to the preoperative status. And this is the lateral view that we are doing here. So again, the 2 views are mandatory, and interpretation of AP radiographs only is, in my opinion, not reliable, because you will probably miss more than half of the pathologies. All right. Yeah. So this is, I only have 2 to 3 minutes left. So this is what we look at of those radiographs. It's only a hip X-ray from left to right. So we look at the steepness of the roof from left to right. So there is a fluent transition. We have the lateral center edge angle, medial center edge angle. We look at the coverage from anterior and posterior. And we also look at how much of the femoral head is extruding. And those are indirect signs of impingement here. And we also look at the type of cam impingement or cam deformity. So there are many types, and you can also see that directly on an X-ray. So we have exostosis-like bumps. You have this extension of the epiphysis. As we see in most of the athletes, you can have clinical, subclinical slips or perthes or other post-traumatic condition as seen here. Or you can have also tumors. So this is something that you really need to check during the evaluation. And sometimes we have those cam deformity also posteriorly, as you can see here. Again, those are the radial cuts that are mandatory for the diagnostic purpose. And I would like to mention that you really need those cuts to diagnose a labral tear. You will not be able to do some diagnostic imaging just based on your pelvic MRIs, which are good for other purposes, but not for this purpose. So look for the cause if you found a labral tear, because most of them are associated with structural deformities, and these are the future imaging means where you can see that we try to quantify the cartilage damage, but it's still in its childhood. I think in summary you can say the concept of impingement or hip pain related to impingement appears to be simple, but diagnosing it is challenging. There are many morphological variations. And I think the dogmatic application of standardized clinical tests may not always confirm the diagnosis. I think detecting painful motion and correlating this with the morphology is the key to success. Thank you very much.